Good afternoon, everyone. I'm Patricia Davidson, Dean of the Johns Hopkins School of Nursing. It's my very great pleasure to welcome you all to today's town hall meeting on a very important issue, prescription drug abuse and misuse. Today we hope to share with you a wide-ranging discussion on what the Centers for Disease Control and Prevention has labelled an epidemic. We are honoured to have President Clinton, guests from the Clinton Foundation, distinguished panellists, experts, stakeholders, faculty, staff and students here with us today. Thank you for joining us here, and also we'd like to welcome those of you who are on our live webcast. And we recognise you as supporters of the School of Public Health, parents, spouses, partners, family members and citizens. All of you are very concerned about what is our nation's fastest growing drug problem. Welcome to you all and thank you for making the time. Thank you for being here to share your knowledge, passion and resolution to seeking solutions to this prescription drug abuse crisis that we face. We know that the misuse and overdoses relating to prescription drugs cause more Americans to die than heroin and cocaine overdoses combined, and prescription drug misuse is the third leading cause of accidental deaths. We continue to abuse prescription medications at an alarming rate. And as the research to the whys, the hows, the what-to-dos moves steadfastly forward to keep up, there's still much work to do. Across the street here at the Johns Hopkins School of Nursing, we've put together a dynamic team of nurse leaders and teachers and researchers who are right at work now tackling this urgent problem. The Bloomberg School of Public Health has likewise put its greatest minds to the task, and together we will solve this problem. Johns Hopkins is uniquely positioned to meet this crisis, and we embrace a moral obligation to help lead the way. It now gives me my great pleasure to introduce our next speaker. Dean Michael Klagg is Dean of the Johns Hopkins Bloomberg School of Public Health. In addition to leading the oldest and largest independent graduate school of public health in the world, Dr. Klagg is a pioneering epidemiologist who has contributed greatly to prevention efforts in kidney disease, hypertension, and cardiovascular disease. Dr. Klagg earned his medical degree from the University of Pennsylvania and his Masters of Public Health degree from the Johns Hopkins School of Hygiene and Public Health, as it was then known. He served as Director of the Division of General Internal Medicine and was the first Vice Dean for Clinical Investigation at the Johns Hopkins School of Medicine. Dean Klagg is the author of over 200 publications, has won many honours and awards, and has led numerous leadership positions globally. He was recently recognised by the American College of Physicians for his contributions in preventive medicine. Here at the #1 School of Public Health in the country, with more than 2,400 students working in over 120 countries throughout the world, we are fortunate in having Dean Klagg's exceptional leadership. Please join me in welcoming Dean Michael Klagg.
Thank you, Trish. On behalf of the entire Johns Hopkins community, I want to echo Dean Davidson's welcome to this town hall. It's a privilege to have President Bill Clinton and so many distinguished guests, colleagues, and friends with us here in this room and at the Bloomberg School, as well as watching on the web. I'm especially grateful to President Bill Clinton, Rain Henderson, Deputy Director of the Clinton Foundation Health Matters Initiative, and our many colleagues at the Clinton Foundation for their vision and leadership in helping us convene this important session. As a physician who practiced internal medicine for 28 years, I know well the risks and the benefits of opioid analgesics and other prescription medications. I also understand that our current situation, where more Americans die from prescription drug overdoses than from motor vehicle injuries, is a complex problem that requires a systems approach to solutions. At Johns Hopkins Medicine, for example, we handle more than 120,000 inpatient admissions annually, and many of our patients are confronted with significant pain. Our physicians and nurses continually manage the delicate balancing act between meeting legitimate needs for pain relief and creating dependency. But some providers are part of the problem, as are some patients. In 2009, for example, roughly 65,000 Medicaid beneficiaries in 5 states received multiple prescriptions for the same classes of controlled substances from multiple providers, on an average of 6 to 10 providers. As part of the Johns Hopkins University, I too worry about our students. The rise in prescription drug abuse and misuse in young people is alarming. From 1999 to 2005, the proportion of college students abusing prescription drugs rose by 93%. From these 2 vantage points, we have some sense of the complexity and scope of what the CDC has rightly labeled an epidemic. And we recognize the inherent challenges in making a coordinated, thoughtful, and effective public health response. To be successful, our leaders and advocates have to marshal the political will to find the needed resources. We must find ways to coordinate between agencies, within states and across state lines, while incorporating the input of stakeholders. To name a few: patient advocacy groups, health professionals, enforcement agencies, drug companies, retailers, and others. And all these efforts must be undergirded by scientific evidence and comprehensive data that can inform and discipline our decision-making. It's in this area, the area of research, that we at Johns Hopkins can have the most impact. Through our Center for Drug Safety and Effectiveness and our Center for Injury Research and Policy, we're working to amass and disseminate the scientific knowledge and data that will help us create new approaches to this problem. And importantly, it will shine light on the gaps in our existing knowledge. For all these reasons, this issue is a profoundly important personal and professional concern for us at Johns Hopkins, and addressing it is consistent with the Bloomberg School's motto of protecting health, saving lives, millions at a time. Progress will require the expertise of partners across the public, private, and non-governmental sectors. In short, the people who will be here over the next day and a half. And it will depend on an alchemy of good ideas, effective implementation, and inspired leadership. To ignite this mix, I can think of no better institution than the Clinton Foundation, and of course, no better leader than President Bill Clinton. President Clinton has spent a lifetime serving the citizens of the United States and the world. After 2 terms in the White House, during which he led America to unprecedented economic growth, President Clinton established the Clinton Foundation, continuing his vision for enhancing economic opportunity, improving global health, and sustaining our environment through path-breaking partnerships that bridge socioeconomic divides, unite leaders across sectors, and transcend national borders. In venues around the world, President Clinton has described these partnerships as the crucial factor for turning good intentions into measurable results. This aspiration certainly resonates on a university campus like ours, where we have a wealth of good intentions. To collaborate with the Clinton Foundation in turning them into measurable results is an extraordinary opportunity. Whether providing access to life-saving drugs to 5 million people living with HIV/AIDS, or uniting global leaders to create innovative solutions to our most commanding challenges, the Clinton Foundation is already making its impact felt in the lives of over 400 million people in 180 nations around the globe. We look forward to collaborating with the Clinton Foundation through the Clinton Health Matters initiative to save lives that would otherwise be ruined and lost to prescription drug abuse. 1 year ago today, President Clinton pledged to staunch the epidemic of prescription drug abuse in our nation. With this commitment, President Clinton and his colleagues are once again proving that our best intentions can become our best practices with the power to transform countless lives. Please join me in welcoming the 42nd President of the United States, founder of the Clinton Foundation, and visionary public health advocate, William Jefferson Clinton.
Thank you very much. Thank you. Thank you. First of all, thank you, Dr. Clegg. And thanks to everybody at Hopkins and the Bloomberg School of Public Health for having us here. Dr. Davidson, Dr. Zeeland, Dr. Alexander, thank you. And to the panelists who will come behind me, I want to thank them, including Dr. Gail Saltz, the moderator, and Peggy Hamburg, who has done a brilliant job, I think, at the FDA. I'm very proud of her and grateful for her service. Senator Amy Klobuchar, Congressman Patrick Kennedy, Dr. Douglas Hough. I'm also bound to say, since I'm here at Hopkins, that my foreign policy aide, who also helps me on all of our international health work, Ami Desai, is a graduate of Hopkins. Therefore, he claims that you get a piece of every life he saves. And I want to thank Jenny Ehrlich, who runs our Health Matters initiative, started our effort against childhood obesity, and will soon be leaving the Clinton Foundation to work as our partner in the Robert Wood Johnson Foundation. None of this would have happened if it hadn't been for her. I will be very brief. The panel's too interesting and too knowledgeable for you to waste a lot of time on me, but I do want to say a couple of things and ask for your help in one way when they start talking. Everybody here knows that prescription drug abuse and misuse is now our fastest growing drug problem, although sadly heroin abuse is catching up rather rapidly. I got involved in this, I'm ashamed to say, from a perspective of total ignorance. Until a couple of years ago, within a 10-day period, two young men, 30 and 32, whom I knew, died in their sleep after drinking 5 or 6 beers and popping an OxyContin. Both of them were given these pills by their lady friends who were totally ignorant of the biochemistry of what was going on. They just said, "This will give you a buzz." And it did, after which they fell asleep and never woke up. Neither of them was addicted to prescription drugs. And neither of them was trained enough in human biology to have any clue that they were about to deaden the portion of brain that told their body to breathe while it was asleep. And so they never woke up. One worked for Hillary at the time in the State Department and had worked for me and was in the George Washington University Combined Program in Law and MBA. One was the son of a Kosovar Albanian immigrant who lived across the street from me. One of 5 children, the only son. And so I got interested in this. And I wondered how many other people were dying either from addiction or ignorance. And we began to do what we could. As you just heard, this is now a year since we have been working on this. And I want to thank a lot of the partners we've had, but especially I am so grateful to the FDA for approving, I think within 15 weeks, some rapid time, a more efficient and user-friendly way to distribute Naloxone. Because it's clear to me that a lot of lives can be saved if we get the production up, the price down, and make it more user-friendly. Our foundation has been honored to work with the FDA and with a lot of other partners, including the people who manufacture this medicine, who recognize that at present volumes it costs too much to be usable, and at present distribution methods is likely to be insufficiently user-friendly to save as many lives when you have a limited amount of time to save them. So I want to thank again all the panelists for the work they do on this. I want to thank the FDA and the White House Office of National Drug Control Policy. I want to thank the JED Foundation, who's been a great partner for us, and I want to thank Patrick Kennedy for all he has done to try to marry our passion for mental health programs that work and substance abuse programs that work. And I know there'll be a lot of talk about here about sharing best practices in the workplace and elsewhere on health and wellness. But I want to ask you all to think about this. Let's assume that the efforts we're making to try to find economically beneficial ways to drive down the cost of life-saving medication work. Let's assume that the FDA approvals mean there really will be easily understandable, much more user-friendly ways of getting the medications into the bodies of people who need it before they die. How do we do that? Our foundation has focused, ever since I left the White House 100 years ago now, on trying to answer a question that obsesses the public health community, but is almost never discussed in our politics. Our politics is a massive debate about what should the government do or not, and how much money should we spend on it. There is too little focus given to however much money you have and whatever you propose to do, how do you propose to do it to turn your good intentions into real changes in people's lives? This is not easy. Both of these young men died at home, in effect alone, because they were asleep. So we need help. We've allocated 3 years, but it makes me sick that we'll have to take 3 years to both get the economics right as we gradually scale up the use and figure out an effective distribution and use system that will at least catch the vast majority of people who would otherwise perish. So from my point of view, the most valuable thing you could do is tell me what we could do to solve that problem and to solve it in less than 3 years. There are a lot of lives riding on this. And if the trends in what we're seeing in heroin continue, there could be more and in more ways. There are other ways to deal with that. You can say whatever you want about that, but I'm assuming we've got this problem. I'm assuming we've got a life-saving answer. And I know we don't really have a clue to get about how to get the life-saving answer to all the problems in time to save all the lives. And that's what I'm obsessed with. So if you can help us on that in very specific ways, I will be very, very grateful. And again, I want to thank Johns Hopkins, where the serious study of medicine began, and where so much good has been done for so long now. And I want to thank all of our panelists for their commitment. But all of you came here because you cared about this, and especially the young people. You need to tell us, what can we do to make sure that now medication that is theoretically able to save almost every life affected by prescription drug abuse can actually do that. Thank you very much.
Thank you and good afternoon. Just to be clear, it wasn't my first choice to follow President Clinton in the lineup. But it is a privilege to be here, and I join our other speakers in welcoming you. I'd also like to thank President Clinton and the Clinton Foundation for shining light on this important topic of prescription drug abuse. This epidemic has touched millions of Americans, and on behalf of these individuals and their loved ones, some of whom are in the room today, I want to emphasize our appreciation. We live in an era of unprecedented possibility when it comes to modern therapeutics. Indeed, when used appropriately, prescription medicines are some of the most safe, useful, and cost-effective treatments that we have. And yet they can also cause enormous injury. Medicines themselves aren't inherently helpful or harmful. Their value ultimately depends upon the ways that they're used in the real world. Prescription drug abuse is a problem that's been a long time in the making and where action is urgently needed. This action must be informed by evidence where we have it and by the rapid generation of new knowledge where we do not. Fortunately, we're not totally in the dark here. We already know a tremendous amount about the genesis of this epidemic, and this in turn offers important guidance regarding how we can best prevent further people from being hurt or lives being lost. When I was in residency training, we were taught that one needn't worry about the addictive potential of prescription opioids if a patient had true pain, and I was part of a generation of healthcare professionals trained as such. Although well-intended, these efforts have contributed to soaring opioid use, so much so that by 2010, enough prescription opioids were prescribed in the United States to supply every adult a 4-week continuous around-the-clock supply of Vicodin. Chronic pain is common, and it's historically been undertreated, and some have framed efforts to rein in runaway opioid prescribing as a threat to quality of care for patients in pain. Yet nothing could be further from the truth. An overwhelming amount of evidence supports efforts to reduce prescribers' reliance on opioids, whether through demonstration of their addictive potential, a number of safer alternatives for the treatments of many types of pain, or the unacceptably high rates of injury and death that are associated with their use in many clinical settings. High-quality care for patients in pain isn't jeopardized by such efforts, it demands it. And this is but one example of where we have plenty of evidence that should inform action now. This afternoon, we're fortunate enough not only to have been joined by President Clinton, but also by a distinguished panel and moderator. Federal policymaking plays a vital role in shaping a public health response to this epidemic, and we're honored to have the senior senator from Minnesota, Senator Amy Klobuchar, with us today. Throughout her career in public service, which includes leadership of the largest prosecutor's office in Minnesota, Senator Klobuchar has built a well-deserved reputation for working tirelessly to strengthen the economy and support families, workers, and businesses. As but one example so relevant to today, she sponsored legislation signed into law in 2010 that allows individuals in long-term care facilities to deliver the most dangerous prescription drugs to law enforcement for safe disposal, and also promotes the development and expansion of drug take-back programs. Another key federal partner is the Food and Drug Administration, whose primary mission is to safeguard the health and well-being of the public. I'm delighted to have FDA Commissioner Margaret A. Hamburg with us here today. A friend of the foundation and university, Dr. Hamburg is an experienced medical doctor, scientist, and public health executive. As leader of one of the most important regulatory and public health agencies in the world, she's been heavily engaged in this issue. We're also privileged to have the Honorable Patrick Kennedy here. Former Congressman Kennedy served 16 years as a congressional representative of Rhode Island and has been an unflagging advocate for causes highly interwoven with today's town hall. He authored and was the lead sponsor for the Mental Health Parity and Addiction Equity Act of 2008, and he knows firsthand what barriers and opportunities exist to advance legislation that look at the issue of addiction and mental health through a public health lens. Our last panelist is Professor Douglas Hough, an author, behavioral economist, and associate scientist in our own school's Department of Health Policy and Management. As many of you know, the field of behavioral economics focuses on how psychological and other factors influence economic decision-making. Standard economic theory assumes individuals behave rationally. Behavioral economics helps us to understand why so often this gets things wrong. A panel as talented and distinguished as this is only as good as its moderator, and here, my friends, you're in very good hands. Dr. Gail Saltz is a nationally renowned psychiatrist, psychoanalyst, best-selling author, and commentator. She is now a clinical associate professor of psychiatry at the New York Presbyterian Hospital and Cornell University, and a regular mental health contributor to Health magazine. Friends and colleagues, please join me in welcoming our distinguished panelists and moderator.
Thank you so much, Dr. Alexander. One person dies every 19 minutes from a drug overdose in this country. And overdoses involving prescription painkillers now kill more Americans than those using heroin and cocaine combined. As the nation's third leading cause of accidental death, prescription drug abuse and overdose is a complicated and fast-growing problem that will require a sophisticated, comprehensive approach including healthcare, pharmacology, manufacturing, and law enforcement policies and practices to address it. We all know that when you only decrease supply, you also increase demand. We also know that various health and mental health issues often drive use in the first place: pain control, anxiety, depression, sleep issues, and the need or the perceived need for better performance. Are we overdiagnosing these needs? Or are we underdiagnosing them, and therefore people are self-medicating? Will different classes of drugs require different kinds of solutions? Is the stigma continuing to keep the problem of abuse and its prevention and its treatment in the dark? How can we come together to create policies that address supply, demand, prevention, and treatment? To explore the answers, I'm turning to my esteemed panel. They're going to address the question from each of their own specific areas of expertise. They will speak for 5 minutes. I will hopefully not have to bring out the hook and take them off. But they will give you their particular viewpoint, and then we will save time for discussion among us, and then we will be answering your questions which you've sent to us. So without further ado, we'll start with the Senator.
Well, thank you so much, Gail, and thank you to Johns Hopkins. And I was thinking, as Dr. Alexander talked about following President Clinton, the first time I ever met him was when he was president. And I got to follow him because he did this major announcement of the hate crimes bill. I was a young prosecutor, really nervous, standing outside of the East Room. And there are hundreds of people in there, and they start playing Hail to the Chief, you know, da, 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 da. And I just start walking. And all of a sudden, I feel this big hand on my shoulder, and this voice says, "I know you're going to do great out there, but when they play that song, I usually go first." That was my first. That, Gail, was my first official trip to Washington. My next was as a senator. So why I am so interested in this issue is that, first of all, I was a prosecutor for 8 years, managed an office of 400 people, and a third of our cases were drug cases. And I saw firsthand that if you got in there and got someone treatment and got them off drugs, it made a world of difference, not only for them, but also for victims and other crimes. Secondly, I come from Minnesota, which, as you all know, is on the cutting edge of treatment. From Hazelton to Mayo Clinic. I like to say that we're not just the land of 10,000 lakes, we're also the land of 10,000 treatment centers. We are proud of it. And then the third thing is that growing up, my dad is alcoholic. He had 3 DWIs while I was growing up, and I saw firsthand, famous columnist that he was, that he could literally, as an adventurer, climb the highest peaks and then sink to the lowest valleys because of his addiction. And the happy end to that story is that he finally got good treatment. He is now 87, happily married for the 3rd time, and visiting Nepal on a trip that he's leading in the Himalayas. So there you go. What I think we need to do here, when I look at the numbers where 100 people a day are dying from prescription drug overdose, I think we have an epidemic on our hands, and it's something that has changed greatly in just the last decade. And so the first thing that I look to is some of the work that we're doing with prescription drug take-back. This is only one slice of the problem, but I think you've all seen the ads of people getting the drugs in the medical cabinet, turning their face. I think they're pretty effective, turning into someone else who's actually taking the drugs out of the medicine cabinet. Well, we have very limited disposal opportunities for prescription drugs in this country. And Senator Cornyn of Texas and I passed a bill, which was mentioned by Dr. Alexander 4 years ago. We're still waiting for the rules from the DEA. It makes it not only easier for long-term facilities to take back drugs, but also for places like pharmacies, if they want to voluntarily do this. Imagine what a difference that would make if people could just bring their prescriptions back when they go get other ones, as well as all kinds of entities, and making it easier for cops to do this as well. We need to get those rules out so we can actually get this implemented, and we're very close. The second thing would be something that's, I know Patrick will probably talk about, but the monitoring of prescription drug. When I talk to the medical director at Hazleton, that's the first thing he talks about, how frustrating it is when you know someone's addicted, but you can't necessarily tell other doctors. Right now, we have a patchwork across this country. There isn't a lot of interoperability across state lines. There are severe funding issues, which the commissioner spoke about with me beforehand, and then there is also the fact that many of them are voluntary and not mandatory. This would be trying to get a better sharing of information of what drugs patients are getting. Final thing I would mention is drug courts. I'm a big believer in drug courts. My state actually has one of the lowest incarceration rates in the country and one of the lowest crime rates. I think that is because we get in early, we use things like probation, and we greatly use drug courts all over our state. We're finally starting to have federal drug courts, and I think approaching these criminal matters in a different way, especially with prescription drug cases, would make a big difference. And the last thing I wanted to mention, the president mentioned heroin, and I want to thank the Clinton Foundation for this incredible leadership on prescription drugs and what they're doing, because there is an interrelationship there. While the vast majority of prescription drug users, 97% or so, never get addicted to heroin, 4 out of 5 of heroin users started with prescription drugs. So we're seeing a kind of heroin user that we didn't see before, and we have to tackle that as part of the problem as well. Thank you.
Thank you so much. Dr. Hough.
Thank you. It's a pleasure to be here. Obviously an honor to be with President Clinton. I didn't have my first encounter with him like you did, Senator, but it was certainly nice. I should say, though, that let me start out by saying that I'm a recovering mainstream economist. I took I got the PhD, I did all the usual things that economists do. I taught all of the equations and all that kind of stuff. And then I came here about 13 years ago to teach in the Business of Medicine program, and this was mostly physicians, but others in healthcare delivery. And I would teach the standard stuff, and they'd go, yeah, well, I guess, because you're the professor, I guess we'll listen to it, but we really don't believe it. And then I would start throwing in some behavioral economics, and they would say, yeah. That's what my colleagues do. I don't do that, but that's what my colleagues do. This is what my patients do. That's exactly what goes on. So as I got more and more, read more and more, and studied more and more, and did some research on behavioral economics, the more it seemed like behavioral economics makes a lot more sense in understanding the issues in healthcare. And then Dr. Alexander, a couple of weeks ago, asked me to participate on this panel. Well, in terms of full disclosure, let me say I'm not an expert on prescription drug abuse, but I guess I would hold myself out as an expert, if you will, in behavioral economics. And so then I started looking into the issue of prescription drug abuse, and of course, being an economist, being kind of nerdy, I started looking at the data and just started coming up with some things, and we'd go, I wouldn't have thought that. And then, gee, I wonder why that is. And of course, I came up with the answer, which was behavioral economics. After all, if what you have is a hammer, everything is a nail. But one of the things I looked at was the statistics that I'm sure you all have seen, is that over the past 30 years, the death rates due to traffic accidents compared to the death rates compared to drug poisoning, and of course, as many of you know, they crossed in 2009. So I started going, well, obviously there is a problem with prescription drug abuse, but the more, and even as much interesting thing is, traffic deaths have gone down. I wonder why that is. Have people gotten to be better drivers? Well, and if you've driven on 695 or 95 or the streets of Baltimore, you go, no, I don't think so. So what happened there? And what happened is we have better roads and better cars. In a sense, we're making these things driver-proof, which then suggested to me, I wonder if we look at prescription drug abuse in somewhat that same way. Not that we shouldn't educate people about prescription drug abuse and those sorts of things, but maybe we ought to be concentrating on the environment and sort of change the environment, change the access that people have to prescription drugs to be using in inappropriate ways. So there are a whole variety of behavioral economics solutions that might be of use there. So that was my first sort of epiphany. The second one had to do with who uses prescription, who's using prescription drugs for non-medical uses, and where do they get these things? My sense was that it was Walter White and Breaking Bad. But no, you look at what the CDC reports, and 55% of people who are using prescription drugs inappropriately get them free from a friend or relative. Another 17% get them from their physician, and from one physician, not doctor hopping. That 11% get them from their friend or relative, but they pay for it, but still they just get it from a friend or a relative, and only about 5% actually get it from a stranger or a drug dealer. So what that suggests to me is that what we've done is, in some sense, created a culture in which using drugs is appropriate, even when you're not using prescription drugs appropriately. And one of the things that suggests is, in addition to trying to get rid of the drug dealers, you also get rid of the sort of inappropriate the writing of scripts. An example is, and we talked about this in the green room beforehand, and each of us had pretty much the same story. And that was, well, when we got a tooth canal or a root canal or had a tooth extraction, that we got a prescription for 20 OxyContin. So I had that, and I went home and I took one and said, well, I'm not taking that again. But I had 19 OxyContin sitting in my medicine chest. And being a good economist, I was thinking, I wonder what the street price of this would be. Now, of course, I wouldn't do that, but it's like what we've done is make these drugs so available that now people have the opportunity to do things with these drugs that they otherwise shouldn't. So in addition to doing the usual things of education and information of patients and such, I think we also got to work on the supply side. Gail had mentioned that when there's supply, there's demand. Even I don't quite believe that entirely, but it says that when there is this incredible supply, it's going to find its way into use in ways that are inappropriate. And so one of the things that we may want to think about, and this may not sound like economics to you, but from my standpoint, it's behavioral economics, and that is one of the things we may need to do is to change the normal. Normal now is if you have pain, any pain, for any length of time, you take a drug. And as a result, people have lots of these drugs around, and when a friend says, oh, I'm not feeling so well, a friend will say, oh, why don't you take one of these? I forget what they are, but I think they did really well for me. And so one of the things that we need to do is to sort of change the normal back to the fact that it's maybe the normal is not that we take drugs for every single thing. And with that, I'll shut up. Thank you.
Thank you. Commissioner Hamburg, thank you.
Okay, well, I think the previous two speakers have already laid out that this is a complex, multifaceted problem, which really requires a comprehensive, evidence-based strategy to address it, and that we have, as a nation, an urgent need to address it. Every day, lives are being taken, lives are being disrupted, and the toll is enormous. FDA is, of course, one player in this picture, but I think we have very important roles to play. I think that together we do, though, need to really make sure that we have a comprehensive approach that really looks at the issues of appropriate physician prescribing and use, that looks at issues of diversion, that looks at issues of appropriate disposal, that looks at issues of ensuring that we can, our physician community and our healthcare system, as well as the broader community, can recognize signs of addiction, and that we have an addiction system that people can rapidly and readily access, and that we can provide treatments that work. The president eloquently and poignantly addressed the fact that many people lose their life to overdose before they can be helped. And again, we need to provide treatments and care to limit that preventable loss of life. And we need to make sure that we are educating everyone, importantly, of course, the physicians and healthcare providers who are writing those initial prescriptions, but all of us need to understand the nature, scope, and urgency of this problem so that we can address it, and address it in ways that will make a meaningful and enduring difference. With respect to the particular roles of FDA, there are actually many. We are obviously in the business of reviewing and approving new medical products. That includes opiate drugs that are needed when appropriately used for the treatment of pain. And as a society, we do have many, many individuals that need to cope with both acute pain, chronic pain, and breakthrough pain. But we need to make sure that we have the right drugs for the treatment of pain and a better understanding of appropriate management of pain. For opiate drugs, I think we need to recognize that we have to really advance the science and technology of abuse deterrence so that we can reduce the attractiveness and the opportunities for abuse of these drugs. That is, I think, an area of growing science, and there are promising approaches on the horizon, but it's an imperfect science at the present time, and it will never be the silver bullet to address this problem. Importantly, especially for chronic pain, we need to recognize that opiates are not always, in fact, probably most often, not the treatment strategy of first choice, but it may be the only option or the option that a provider may know best. But we need to really work, and FDA is actively engaged with the scientific research community and with industry to try to develop new non-opiate, non-addictive pain treatments for very, very important pain syndromes that really disrupt the quality of life for many individuals. And we've actually been able to approve recently several such non-opiate pain medicines, but still much more to do. The medical treatment of addiction is very, very important, and another arena where we play a critical role in terms of helping to develop better, safer treatments for addiction that can really work to change people's lives and to interrupt the dreadful cycle of addiction. And of course, we need to make sure that these products can be made available in a treatment system where doctors know how to use them and also how to recognize patients who need treatment for addiction. We already talked about, the president led off the discussion, the recent FDA approval of naloxone, which does allow you, through an auto-injector like a epinephrine pen that some of you are probably familiar with, to actually reverse an overdose in the community, because previously naloxone was really used by healthcare providers as an injection drug in healthcare settings, hospitals and clinics, and sometimes by law enforcement who had access to the drug but weren't officially licensed to be using it. This is something that now can be used in the community, and I think will really save lives. And it's a first product that we hope will lead the way for other products in this same class that again can save lives, recognizing that those individuals who've overdosed and need naloxone most importantly need treatment for addiction. We want to save the life so that we can get them into treatment, ongoing care, and that's a very exciting opportunity. So I see the signal. I was watching the clock there. I didn't think I was too much over, but I will stop there so we have opportunity for discussion.
Thank you so much. Thank you. Congressman.
Thank you. So I retired from Congress 3 years ago, and I went to New Jersey, and I got married, and have had 3 kids since then, so I've worked very quickly. More productive than I would have been in Congress, that's for sure. So I'm in recovery from opiate addiction and alcoholism, and pretty much anything that I could get my hands on that would change the way I felt. So I go in and go to my new doctor, and I go in there and I say, hey, doc, you know, I'm in recovery from addiction. I have high cholesterol. You know, I take Lipitor for that. I'm also a chronic asthmatic. I have Ventil and Advair singular. And, you know, here's my medical profile. I go see a dermatologist quite frequently because I've got this Irish skin. So the doctor said, great, you know, let me get into this. So he goes to his computer and he starts tapping away. He goes, so tell me about your asthma. Like, does it interfere with your sleep? And I said, well, if I don't take my inhaler, well, how many times a day do you take your inhaler? Well, I said, perhaps too much. I mean, at least 4 times. Well, aren't you using your long-acting? I said, he keeps typing in his computer. And I said, well, I should use it some more. And I've come to you because I need prescription for that, too. Okay, great. Now, on your cholesterol. So by the time the thing finished, I get up, I start walking to the door, and I said, hey, doc, by the way, you know, you saw that scar on the back of my neck, halfway down my back. I had terrible surgery, you know, 14 hours. I mean, it was, you know, I got some residual pain from it, and it would be really nice if you could write me a script for OxyContin. In fact, you know, anything over 20 milligrams would be preferable. And he looked at me kind of funny, and then he goes, didn't you tell me you were in recovery? And I said, yeah. And you didn't ask one question about it. So you asked, you know, 5 to 10 minutes on my asthma, asked about my cholesterol, but long before I die of an asthma attack or a stroke, I'm going to die of my addiction before anything else, because that's the thing that's nearly put me in the grave 6 times. And you don't even know about the most important part of my health care, and you don't even have the computer prompts to ask me about it. You don't ask about my recovery. Am I on the wagon? Am I using my meds properly? You know, what's going on in my life? Blah, blah, blah. Now, if he were to ever do that, he'd need to get reimbursed for it, because most doctors said, oh, they'd do a profile if they were ever paid for it. So that's where my other hat comes in, because I'm like that hair club for men guy. Not only am I the sponsor of the Mental Health Parity and Addiction Equity Act, which requires insurance companies to pay for this treatment, I'm also a consumer who's been in and out of rehabs and ERs my whole life because our medical system does not reimburse for chronic care management for those who have addiction and mental illness. So one of the answers is we need to pay for access. We need to pay for those kind of preventive measures that will only come when we start treating addiction and mental illness like we do asthma, like we do cardiovascular disease, like we do diabetes. We wouldn't imagine telling someone with diabetes, come back until you need your legs amputated and you go blind. We wouldn't imagine. If you had cancer, we wouldn't say, come back when you have stage 4 cancer. But that's exactly how we treat addiction and mental illness in this country. We wait until it becomes a crisis, and then often insurance companies say you have to fail first before you get led into a treatment facility. And of course, no preventive health care is provided along the way. So I would propose a checkup from the neck up in our pediatrician's office, in our primary care physician's office, in our orthopedist office, in our gynecologist and obstetrician's office, and our geriatrics office. If we're not asking about your mental health, you're not doing what you need to do to get to the real health issues that are, as you know, in a public health setting like this, the real cost drivers in healthcare today. 3 out of 4 are all behavioral, and yet we segregate the mental health and behavioral health care system from our physical health system. And until we combine the two and stop this age-old mentality of segregation in this case of our mental health versus overall health. And by the way, the IT is not linked, so there's no way for doctors to know that I've been in those rehab settings. We need to address these problems, and if we do, I think we'll catch a lot of these problems in the way that we would any other chronic illness.
Thank you so much, Congressman. So we're going to start having a conversation. I also just want to preface and say we've been talking a lot about pain medications, and that's certainly a big category, but I hope that people understand that there are other prescription drugs that we're very concerned about, categories like benzodiazepines, like stimulants for the treatment of ADD and so on, that are also huge problems in terms of addiction, in terms of causing disability, and in terms of death, and combinations of these drugs as well. So I just want to mention that. Dr. Hamm, I'm going to start with you. In the area of physician responsibility, doctors are increasingly rated by patients. I'm sure you've probably all had this experience, right, in one way, whether it's on the internet or whether we're moving toward a really official, necessary rating of physicians. And physicians have to balance now being rated, having a business, with patient satisfaction, and sometimes patient satisfaction being that a patient comes in and asks for a medication, a drug that perhaps the doctor wouldn't necessarily have prescribed, but is now going to risk sending away an unsatisfied patient. Can you speak to, because this seems like a dilemma, an inherent dilemma in the system?
Well, I can speak as a physician. Actually, the FDA does not regulate the practice of medicine, so this is, more from the perspective of a physician. But, I think one of the things that's absolutely crucial is having the appropriate education and training about, how to use these powerful drugs. And as you rightly point out, we're not only concerned with prescription opiates, although they certainly are a major focus of concern in light of the growing patterns of abuse, misuse, addiction, and overdose. But I think we need to pay more attention to really, adequately training physicians in appropriate use. Now, FDA has a critical role there in terms of providing information that hopefully is both accessible and clear about appropriate use. And in the area of opiates, especially the extended release long-acting opiates, which contain the higher doses, we have fairly recently put additional restrictions on use and strengthened and made more pointed the warning labels, the informational labels about what these drugs are, when they should be used, whether, really telling the physician about the addiction potential and the need to assess, is this the right drug for the patient that's before them, and reminding them of the responsibility to monitor for signs of addiction. Also requiring companies to provide physician education and training through a certified continuing medical education provider to also enhance the appropriate use. But when you're in your office, and I'll confess I haven't actually been in an office as a physician as recently as I've been as a patient, often the pressures that the current healthcare systems puts on doctors to move patients through, the additional pressures of ratings, et cetera, often misaligns the incentives, and I think my colleague, the behavioral economist, can speak to that as well, but we need to think very carefully about what's in the long-term best interests of patients, our healthcare system, and public health.
But by setting up warnings, by setting up warnings, you give physicians essentially some ammunition to be able to convey to a patient, this is dangerous, and let me explain to you how.
Right, and we also now, really put an emphasis on the medication guides, and for the opiates, that is information that the physician may not previously have been providing. But we also recognize that, we're talking about an environment that is sending very different messages than necessarily what the physician is sending to patients, and the physician may choose not to discuss an uncomfortable issue, and one that they may not feel very expert in either.
Yes, Dr. Hough, did you?
Yeah, let me give you an example. Michael Barnett from Harvard did a very interesting study in which he found that 73% of the patients who presented with bronchitis were given an antibiotic, even though only 5% of the time is it appropriate. 60% of the time that patients presented with a sore throat, they got an antibiotic. Well, that doesn't require a whole lot of education. Physicians know this. And the question is, well, why do they prescribe it? It's not malpractice. Why do they prescribe it? And the answer is probably several-fold. One is they're thinking, well, it probably isn't going to do the patient any harm. At best, maybe it'll be a placebo. And by the way, I've got 7 patients in the exam room, in the waiting room already. I need to go through these patients. I could spend 20 minutes explaining to the patient why it would be a good idea for me not to prescribe these, but I'm not going to get paid for it, and he's probably not even going to be listening because he thinks his sore throat, his bronchitis needs to be cured now. So this whole issue of action bias on behalf of patients, a behavioral economics term, is really prevalent out there.
Yes. Let me move to Congressman Kennedy. As you were explaining, actually, abuse often begins because of various mental illnesses that are untreated, and lack of ability to get care, lack of services being available in certain parts of the country. Really, services are tremendously lacking. Stigma regarding getting treatment, so many people who know they probably need to come in simply won't. These conspire to increase the likelihood that real treatment, and particularly non-pharmacological treatments, so psychotherapy or therapies that could help with whether it's pain or sleep or a mental health issue, but would cost time and would cost money and may not be available, are making it difficult, I think, for many people to get the kind of attention, as you said, above the neck. What, I think you are working on this somewhat, what can be done to further the likelihood that patients will get the attention for those sorts of things so that they don't feel as much of a need to self-medicate?
Well, as Dr. Hough said, I mean, the behavioral economics are that in my own life, I haven't had to go to the ER in 3 years since I've been in recovery. I was going to the ER all the time before that. I had back pain, I had irritable bowel, I had, I got into accidents all the time, I needed stitches. My medical spend dropped precipitously once they treated the underlying issue, and I got into real. So this isn't a matter of saving money by cutting or paying more money for doctors to do the screening early, because all the costs, the insurance companies are going to do the health economics, doctor. They're going to recognize that it pays to have someone in the office doing that screening, brief intervention, referral, and treatment, and maybe working so they support the doctor, not take up all the physician's time. This can be done. And yet, it isn't done in this country. There is no HEDIS standard, okay, how you get measured as a provider group on whether you hit these HEDIS benchmarks. There's no checkup from the neck up. And the real key to this is you got to make it absolutely part of medical treatment. And we can do it. We can do it today. And it would seem to me insurance companies ought to be all behind this, that this place ought to be promoting this to insurance companies as a value added as opposed to a cost, because of all the indices we have in terms of the ramifications of not treating a mental illness and a concurrent addiction issue.
Depression is the #1 source of disability, #1. So, but obviously, if something preventive was done about that,
but
it
again,
would be very different.
So you want to change the world, we got to get away from these carve-outs. So the insurance companies are giving mental health and addiction over here, and then they manage your physical health over here. I mean, that stuff has got to change. And having leaders from Bloomberg and what you do at Johns Hopkins could be very helpful in us doing that, because this is the fundamental time of healthcare reform, and we need thought leaders and people with great deal of credentials coming out and saying we got to scrap this old segregated system and make it routine part of overall healthcare to do this early on and throughout your life.
Thank you. Senator. So one thing that has become clear as all of you speak is that a lot of the abuse is with legal drugs being used in illegal ways. And how much of that is the perception on the part of the person using that what they're doing they don't perceive as illegal, or how much is it that they do, but they're not really that concerned about the consequences? What should the consequences be that might improve their concern about it being illegal?
Well, I think at some point, a lot of the people, not the case that President Clinton talked about, where someone maybe just one time or a few times takes a drug that has an interaction, but most of the time, I think there's a point where people realize it's illegal, that what they're doing to feed their habit, they start as, I'm looking over the Economist, because I feel like everything I'm going to say is going to check out the numbers, but when I was listening to his numbers about how people got these drugs, yeah, sometimes it's from their doctor, but when they start getting it from friends and start buying it from other people, a lot of those people are doctor hopping, or they're getting drugs in some other illegal way. So you have to look at the chain and where those drugs are coming from. So I always look at demand, which to me means a lot of what Patrick was talking about. And by the way, he was an incredible leader on the Wellstone Domenici mental health parity bill after Paul died, which meant so much to the people in our state. Thank you. And then doing that, and then on the supplies, the demand side would also be when people get caught up in the criminal justice system, to look at drug courts where instead of just straight penalties, where we know 3 out of 4 people that graduate from drug courts end up not coming back into the criminal justice system again. But on the supply side, getting to your question, I think, first of all, doing what we can to monitor where these drugs are going out between physicians. And that's not an easy topic, but if we really want to get some kind of handle on this, we have to get a handle on not only changing the norm, as my friend over here talked about, and changing the limits of what people get. It is also looking at who's prescribing and how much they're getting and keeping better track of them through these prescription monitoring systems. And then the other thing I'd point to is this idea that we have so many drugs in our medicine cabinets. They used to tell us, when you couldn't figure out what to do with these drugs, they would say, flush them down the toilet. Like, who wants to do that for the water supply? Or my favorite, as a busy mother, was when I heard you were supposed to grind them up in coffee grinds. Okay, so you're going to, let's be realistic that maybe I know some people in this room will do that, but not everyone's going to do that. So now we turn to, well, bring them somewhere where it's legal. And just to give you a sense of the demand out there for bringing back drugs, one day in April, just this last April in 2014, 380 tons of drugs were brought in, 380 tons in one day in the United States of America for these drug take-back centers in police departments, and in Minnesota, we're a little more, we use libraries. And so when you think about that kind of pent-up demand, and that's why Senator Cornyn and I passed this bill, and you could start bringing things in more easily to pharmacies and long-term care facilities. So I'm just looking at a sort of broad spectrum of ways to look at that supply and to meet his economist demands to reduce that supply. And that is definitely one of them. And then the other is the prescription and education and so many of these things we talked about. Because you're right, people think when they start doing it, a lot of them think it's legal. They have and it is legal. They have an injury, something goes wrong, and then they somehow get hooked and they can't get off it. So I would think that the medical community, and we have some great doctors in this room and people in this community, have some obligation to work with us on figuring out how we put the limits on it.
Were you able to find any evidence in terms of the take-back program, besides the huge numbers of drugs coming back? Was there any sort of reverberation or ripple in terms of what you saw as a fallout from people who were abusing?
Well, again, I was just asking our great staff that. There she is back there. Hi, Kirsten. To get some statistics on that I think we need to, it would be, the way you would probably do it is look at areas that are really doing it big time, like ours and other places, and then see the effects. 'Cause I don't know if it's been studied yet, but I know someone that can look at it.
Mm-hmm. Okay. We'll look forward to that. Thank you.
Can I just make another
yes.
point on the medicalization? So we have this new drug introduced that's sweeping the country, and it's called marijuana. And for a lot of folks who are worried about this opiate problem and heroin overdose, I mean, now you can smoke it in these e-cigarettes. You can just put THC and nicotine in these electronic cigarettes. Snoop Dogg is promoting this stuff. He's got his own brand that's targeted to high school kids. I mean, we really have to look at the bigger picture here because it's whack-a-mole. You know, you knock down the Oxycontin over here, it pops up in the heroin over here. You try to address here. We've got to take a much more public health approach to addiction in general. And there is something to this notion of gateway and permissiveness. And just like medicine feels like, oh, it's good for you, it's medicine, we're going down that road on this new third legalized drug as well.
Well, actually, I was going to bring that up later, but if anybody else also wants to comment on the marijuana issue, certainly there's been some recent data about IQ points dropping over the long haul of frequent use, brain changes even in mild use of marijuana. So the question becomes politically and economically, obviously there are certain incentives to legalize, to further legalize. Does anybody else want to comment on, you know, I think what the congressman is saying, that there really are concerns about whether this will be a gateway. There's a certain population that when they do use that will go on to have psychotic disorder. It's a small group, but we don't know who it will be, and we don't have data. The problem is we just don't have data.
And I was going to say the same thing. We really do need much more science for decision making, and certainly in the area of medical marijuana. You know, one of the things that we talk about at the FDA is the need to really make sure that critical research is done to really find out what are the syndromes and disease conditions where marijuana works, and you know how to make sure that people aren't potentially exposing themselves to something thinking it will be treating a disease condition when in fact it is not. Perhaps they're foregoing another treatment that would have value for something that in fact hasn't been proven to be effective. And of course, from a regulatory point of view, you know, a lot of issues about what's actually in the product that's available in the marketplace. And, you know, just because it's labeled marijuana doesn't mean that it doesn't contain other things that could be harmful to health. So I think we really do need to learn a lot more.
But my point, I'm sorry to make this point, is that kids are stressed, and there's no coping mechanisms out there. There's no, you know, education, public health in terms of how do you deal with your stress. And I just think we need to think this through a lot more. We have, you know, Jed Foundation here. I mean, the suicide rate, 1,400 kids in colleges and universities are going to take their lives successfully this year, 38,000 Americans. I mean, we just really need to be focused on this because we need to build resiliency. We need to build coping skills, stress management. I mean, it's crucial because if you have this stress in the economy, no matter what the latest jobs numbers say, is very unsettling to young people in terms of what their prospects are out there. But you say, I've got a solution for you, smoke this and you're going to feel better. I mean, that's what our country's doing right now. It's the message that we're sending young people. If you feel really stressed, there's a way out. I think it's a bad message for us to be sending.
I want to quick go back to the prescription drug issue with students and kids because Gail had asked about, well, do we have the numbers on what happens with the takebacks? Well, what we do know is the number 2 addiction for kids right now is prescription drugs. And they, for the most part, aren't getting the, you know, back injury, for the most part, where they're getting it prescribed. They're the ones getting it out of the medicine cabinets. And so if you can get those drugs out of the medicine cabinets and make it easier for parents to get them out of there, there's absolutely no doubt that you're going to reduce the chance that they're going to get addicted.
I also wonder if it might have an impact. There was a study of 81 college students with ADHD which revealed that 62% diverted the medication to someone else without a prescription. I mean, kids are just sharing it with each other on college campuses.
My daughter just came home from her first year in college, and no, I'm not reporting that she took these drugs. She did not. But I was just talking to her about exams, and there was a kid in her high school that committed suicide yesterday that she knew just a little bit. And we were talking about the fact that he had this intense, he went right to work in Silicon Valley and had some intense job, and I raised the fact, I wonder if he was, I had no idea, doing drugs. And then she said, well, Mom, a bunch of the kids take stimulants and drugs to get through the exams, and that is exactly, she said, Adderall and those drugs. So that's
it's ubiquitous. I mean, well more than half of college students are offered something, within a year of college. They need a mother like me who's constantly texting her kid at college saying, "Don't you dare take that." But unfortunately, there aren't enough of me to go around. So what else can we do?
That sends the studies and says, maybe you'll want to run a story about this for the school newspaper. That's not my beat, Mom.
No. Well, I mean, these are important comments and good strategies. At the same time, in some sense, they're assuming that people are rational. That if we do the studies and show them the statistics, then they will make the right choice. But one of the things, come back to behavioral economics, one of the wonderful concepts in behavioral economics is something called hyperbolic discounting. It's a wonderful phrase. You can use it at cocktail parties. And it says not only do people prefer the present to the future, but they really prefer the present to the future in such a sense that they get sort of hyper on the present. So if you see the benefits of these diverted drugs, now I can get through exams, or I'm in a stressful moment right now. This will get me through. The downstream consequences 10, 20, 30 years from now, well, those are so far down the road that I don't have to think about them. So one of the challenges, and perhaps one of the solutions, is finding ways of either reducing those benefits or making those consequences, the negative consequences, really salient to people. And in some senses, statistics, but it's personal experiences. The two examples that President Clinton gave were probably provided better evidence, if you will, than all the statistics in the world, because they're real people who were people who were like us.
Right, you can't draw a line between I'm not like them. Exactly. Another huge issue is that pharmaceutical companies have an objective to make money. And they have that duty, that fiduciary duty, actually, to their shareholders. And pharma is the largest lobby on Capitol Hill. So however many of you feel that you can speak to what can be done about the fact that really, in essence, that may be at odds with trying to solve this problem, at least from a policy standpoint.
Well, I think we have to try to incentivize the industry to do the right thing and to try to make the products that really address critical medical care and unmet public health needs. You are right, there's a broader context in terms of motivation, but I think that that is a strategy that certainly has to be pursued. And as I mentioned, we think there's huge opportunity in terms of where the science is going and the deeper understanding of how the brain works to develop new, better drugs that are not in the opiate class, that will not have the same addictive potential to treat pain. Huge markets for these drugs. We need to get, that as a focus. Again, trying to address, if you are going to be in the opiate business, how can you develop opiates that have more abuse deterrent properties? And that's another area where, certainly, we're trying to help support industry to move in that direction, and we're hoping that, in fact, in the marketplace, they'll see economic incentives as well.
Also, direct-to-consumer advertising of pills is, well, ubiquitous of medications, and you would watch commercials and believe that, frankly, there's just a pill for everything. And I think that everybody has come to absorb that message that they probably are that person walking with a little black cloud over their head or whatever the commercial. And despite the fact that many of them tell you all the horrible things that will happen to you when you take this drug, it doesn't seem to have an impact. But it also sends the message that the patient knows what medicine they should take. And so they should be able to go into their doctor and tell their doctor what medicine they should take. What, can any of you speak to this? What do you think needs to happen in terms of the impact of this? I think it's a significant impact.
We have to realign the incentives. You get what you pay for. So we pay for drugs. We don't pay for other therapies that can act as other alternatives to drugs. So what do we get? More drugs. Until we figure out a way to get the economics where we can lump all the money that a spend would be for medical for me and think about what it would be to move the outcome for me or any other patient, you'd recognize that a lot of non-medical services could be crucial in reducing my rehospitalization rate or my reincarceration rate or what have you. It's just not rocket science. Let the capitalists market. Can you imagine me as a Democrat candidate? Say, let the for-profit system have a true for-profit incentive to get an outcome. We're not paying for outcomes. We're paying for services. We're paying for the number of pills delivered, number of prescriptions written, number of services provided. We're not paying for how are we going to get that person better to the point where they're even feeling better and sadder.
I actually have proposed getting rid of the tax deductibility for the advertisements for the drugs, just because I've just never seen that merit, and I've seen a lot of the costs, because I think those drugs should come through the doctors. But it is what it is. I've also proposed allowing you to get less expensive drugs from Canada, renegotiation under Medicare Part D to bring down the cost of these drugs, and it is, thank you, sir, thank you. It is, and I've done bills on all these things and working on another one on the Canada front. But it is, as pointed out, they have a lot of power in Washington, and it is very difficult to get things done. So what I go back to is, under the Affordable Care Act, we worked very hard to put in some incentives for high-quality, low-cost care. From my perspective, from a Mayo Clinic, Minnesota perspective, and I don't think it was quite as far as it should have gone, but it is a good beginning in terms of rewarding hospitals if they have lower readmission rates, in terms of rewarding doctors for cost-effective care. And I think that delivery system reform has just begun, and it is a very difficult thing to take on, I think. But we all know every time we want to do something compassionate and talk about talking to patients who are chronically ill about what the real choices are and get their families together, we're labeled as doing death panels. And I think that we need to continue that work on the high-quality, low-cost care, and that is going to be the best thing we can do, because if you look at the systems across the country, you would think high cost means higher quality, and it is nearly the opposite.
And since we're sitting in a school of public health, I feel obliged to also say, let's put more emphasis on prevention. Let's try to stop these problems from happening in the first place.
Absolutely. Let me take some audience questions. So I think whoever, unless it's very obvious, if you feel you want to chime in, please do. Actually, Commissioner, I think you may want to answer this one. Many states have adopted opiate guidelines. Do you see?
He's laughing because my sleep thing kicked in on the Fitbit
and
for some reason.
Your sleep?
I don't know. Must have been like, I don't think so. I think we're okay.
All righty. Many states have adopted opiate guidelines. Do you see national guidelines or federal systems set up similar to the REMS program, and maybe you can explain what that is, holding patients and physicians accountable by signing opiate contracts?
Well, I think we're, examining what are the best strategies to really ensure the most appropriate use of these powerful drugs, and there are different ways to approach that. And certainly I think that better physician education and better oversight of prescribing practices is very critical, whether it happens at the state level or the federal level. The REMS is something that FDA is responsible for, and its risk evaluation mitigation strategies. And for the various classes of drugs, we have different ways that we try to really try to address the issue of appropriate use and limiting dangerous or inappropriate use. And for the opiates, for the extended release long-acting opiates, we recently did institute several strategies that we hope will make a difference. These drugs, of course, are Schedule II, so they're subject to certain prescribing restrictions, and you can't have refills and other requirements for reporting and security. But in addition to that, through our actions, there are now requirements for the drug sponsor to offer medical education for prescribers. I think I already mentioned that. There's a requirement for post-marketing studies to really continue to better understand real-world use, and requirements for providing medication guides that hopefully are the stimulus, the catalyst to have physicians actually talk with their patients about how these drugs should be used and stored and disposed of. So I think that that's very important, and actually with the REMS, we periodically assess the impact so that it's a dynamic process, so that if we determine that more needs to be done or we need to address a problem in a different way, and we anticipate doing that for this class of drugs, really beginning in the next couple of months. But I think we need to do a lot more in terms of providing the appropriate oversight, and as Senator Klobuchar mentioned, I think that the physician prescribing registries are a very, very important approach, but as yet really underdeveloped in terms of their potential, with different states having different strategies, lack of real time, lack of integration of important databases. And so I think we really should look at that and really support them and look at the best practices that have already been emerging in states across the country, and try to build this program up into something that will really be meaningful in terms of oversight of physician prescribing and patient drug-seeking behavior.
One of the reasons I just voted against the SGR fix last time was because we keep doing it year after year after year. This is the Medicare rate issue, but also because we delayed for a year the requirements of coding the medical records, which many states had really gotten ahead of, and we're going to meet the deadline, including my own. And to get to this point where we're going to be able to have this interoperability of medical records and get to the point where we are going to be able to share medical records, not just to catch prescription drug overuse, but also to catch people's medical conditions so doctors don't give them the wrong prescription. We have to get our medical records matched, and I have found it frustrating that we're not moving faster. I know there are many barriers to that with different hospital systems and privacy concerns, but it seems to me there should be a way, when we are dealing with this many lost lives and this much lost money, that there should be a way to do this. And I know it's not easy for people to get their arms around, but there's no reason in a country as advanced as ours that we're not able to see what a patient's medical history is and not be able to get an alert up there that says this is someone that has gone to 3 different doctors and asked for these prescription drugs. There should be able to be an alert that comes up on the medical record like that, so that doctor has full information.
It needs to be national. I mean, in New York we have iStop, and but patients go to New Jersey or Connecticut, and this is the problem.
Yeah.
Congressman Kennedy, did you
So we're near Washington. It would be appropriate now to talk politics. And one thing that we could do is get some of these recommendations, put them in an executive order, and ask the President of the United States to sign it, because this is an epidemic, as has been said over and over again, and we need a response yesterday to the issue that physicians aren't educated. They're writing these things left and right. You could do all of these other things that Commissioner Hamburg said, but we need to get it implemented. We can't wait for Congress to think they're going to pass a law with the way they're getting around to passing laws these days.
Thank you, Patrick, and, now that you're gone.
You get my point.
One aspect about the question that they asked was that a patient will sign a contract There's plenty of research that's demonstrated that if people have to sign something that says, I will be truthful on this exam, I will not steal, there's plenty of example that on the margin that they will be more truthful. Now, is it going to be big? Probably not. Is it going to solve the problem? Probably not. I know it won't. But one of the aspects of all this discussion is that there is, and Commissioner Hamburg's comment, that there is no magic bullet, and at best what we're looking here for is magic buckshot. I mean, to see the different kinds of things that can be done that will make a difference.
Well, the point that people are more likely to, let's say, lie by omission than to outright. So in other words, if a physician asks, have you been to another doctor, have you gotten this elsewhere, a certain number of people will be caught in that. Okay, the armed forces is experiencing an increase in prescription drug abuse from PTSD, and I think from other things. Soldiers are being discharged without treatment. That is certainly the case. Where can we find funds, basically, that can go to, I guess, increased mental health care and addressing the abuse issue for our vets?
Well, one of the things that we have done better in the last decade is we have greatly increased our funding for veterans care. After the Walter Reed fiasco, we actually put in place the largest increase for veterans health care in the history of this country. It was the acknowledgement that we have vets from past conflicts that are still getting treated, and then we have a number of current veterans coming in with the signature treatment that they need is for traumatic brain injury. So that's what we have going on. We still know, especially these last few weeks with what we've seen in Arizona and the investigation going on, that there are still major problems with our veterans' health care. And I am not familiar with how the money's being divvied up when it comes to addiction, when it comes to mental health care, but that's something I'll look at when I get back. But we clearly are aware of the enormous number of suicides we've seen from returning vets in post-Gulf War. We have seen them in my own state. We've instituted for the National Guard a major program because they don't go back to an active duty base. They go back to little towns all over the country. And we actually were the first state to do something called Beyond the Yellow Ribbon, where we require them to come back every 3 months to get a check to see how they're doing with their mental health, to see how they're doing, if they're addicted to anything, if they have a job. And those are the kinds of things that have to be a priority right now, as we have a number of soldiers that are now coming back that have been deployed for years, and that includes mental health care and addiction.
Well, unfortunately, you can see what an incredibly complicated problem this is, and we're going to continue to put our heads together and work on this problem. I want to thank you all for coming. I want to thank the Clinton Foundation for putting this together. This is a very serious, very complicated problem. We've got the brightest minds on it, and hopefully with that we will be making some headway. So thank you. Thank you.
Good afternoon. My name is Andrea Gielen. I'm from the Johns Hopkins Center for Injury Research and Policy, and I realize I'm standing between you and the reception. So I will be brief, but I'm honored to have an opportunity to make some closing remarks, and in particular to thank Dean Clegg and Dean Davidson for their encouragement and their support of the efforts that brought us all here today. We couldn't have done it without them and without the wonderful collaboration and extensive contributions of the Clinton Foundation. Having President Clinton kick off the session was not only incredibly moving, but was something that will continue to inspire us as we move forward to solve this public health epidemic. Thank you, Dr. Saltz, for being such a wonderful moderator. You facilitated a stimulating and thought-provoking session. Dr. Hamburg, Senator Klobuchar, the Honorable Mr. Kennedy, and Dr. Hough, your remarks enriched our understanding of the many varied facets of this complex problem. As a result of our conversation here today, we're in a much better position to appreciate the regulatory and policy environments that shape people's exposure and access to drugs that can lead to abuse, addiction, and overdose. We've also been challenged to think about the need for prevention programs and treatment services and the ways in which healthcare systems can hinder or facilitate controlling this epidemic. Moving forward, how we frame the epidemic of prescription drug abuse, misuse, and overdose will be important. Framing shapes our discourse, and as Dr. Alexander mentioned in his opening remarks, determines the conceptual paradigm that we use to identify solutions. I can't help but think about the many parallels between our current situation with prescription pain medications and where we've been in the past with another very familiar public health problem, motor vehicle-related injuries and deaths, as Dr. Hough alluded to. You may know that motor vehicle safety was named by the CDC as one of the 10 greatest public health achievements of the 20th century. What can we learn from this injury prevention success story that's relevant to what brings us here today? Well, at the center of the problem was a product that's needed for good reasons, but that can also be hazardous. The challenge with motor vehicles was to design a safer vehicle and a safer environment in which it's used. Both were achieved only after many years of scientific advancements and efforts to translate and disseminate this body of knowledge. With a safer product and a safer environment, the challenge of helping the individual users be safe was definitely made easier, but still required policies and programs that reduced risky behaviors such as drinking and driving, as well as the delivery of effective trauma care when prevention fails. The players involved in the motor vehicle success story were from most, if not all, of the same disciplines as those addressing today's problems of medication misuse, abuse, and overdose. Manufacturers, retailers, insurers, legislators, regulators, law enforcement, healthcare providers, health services researchers, public health researchers, and professionals. I hope I didn't leave anybody out. As a result of their collective efforts, and in the face of enormous increases in the number of vehicles and the number of miles traveled, the motor vehicle death rate per vehicle mile traveled has declined by more than 75% since the 1960s, demonstrating what should be obvious to all of us is that public health approaches can succeed. And the parallel here should be obvious. Unfortunately, the prescription pain medication use has skyrocketed, so have the number of deaths. To address this, we may want to draw on an approach used in motor vehicle safety and many other injury problems, which we refer to as the 3 E's of injury prevention: engineering safer products, enforcing safer environments, and educating all levels of society. As we heard in today's discussion, many steps are currently being taken along these lines, and there are some victories already achieved. But we have much work left to do, and today's meeting is just the beginning of an initiative that convenes key stakeholders so that we can better understand the problem and find solutions. In addition to thanking all of you who spoke today and all of you who joined us, we want to thank the individuals who will be continuing to work with Johns Hopkins and the Clinton Foundation in tomorrow's working session. Our goal in convening this smaller working group of diverse stakeholders is to come to consensus on where the research is strong and needs to be communicated to support evidence-based decision-making and where there are knowledge gaps that we must address. We will widely share the results of this effort and look forward to continuing to dialogue and work with many of you here today. We hope the results of today's meeting and tomorrow's work session will help shape a comprehensive national approach so that in the not-too-distant future, reductions in prescription medication misuse, abuse, and overdose will be the next great public health achievement. Please join me in once again thanking our speakers, and we'll look forward to seeing everyone at the networking reception in the gallery. Thank you very much.